I'll use a higher stimulation to get in the general neighborhood of the nerve, and then as I get closer to the nerve, we'll switch down to a lower polarity so I can actually get down to 0.5, 0.3 if need be. Especially if I'm really trying to make a distinction between branches of a nerve. So for instance, trying to get a high saphenous nerve, trying to make sure you're not getting any of the femoral stimulation and only getting the sensory stimulation or the saphenous stimulation. In the same way, I do believe I always check motor, even if it's a pure sensory nerve. Dr. Trescot, how do you know that 6 years ago you did motor stimulation? It's because I always do motor stimulation every single time. And to make sure I'm not close to a motor nerve that I don't expect to be. Now, there are a couple of times when I actually will use motor stimulation to find the nerve. Suprascapular nerve is a great example. You can find it with sensory stimulation, but it's easier to find with the motor stimulation. And so there I'm deliberately freezing a motor nerve, and I'm deliberately using the motor stimulation to find it. But most of the time it's the sensory stimulation that you're using. Okay, so we're purging this. I do recommend that you, especially when you're first starting, that you make sure that you use, well, two things. I recommend you use an introducer, and then I also recommend that you test that your introducer will work. There are a couple of changes that have gone on to some of the angiocaths to make them less likely to stick you. And when they've done that, they've changed the internal diameter of the catheter. So the classic is the angiocath 14 gauge. Some of them have a little metal ring in here that makes the diameter too small. And there's nothing worse than having gotten your introducer exactly where you want, and now you go to put the probe in and it won't work. So I've just gotten into the habit of trying to make sure that my introducer will fit. I do believe in using an introducer for a couple of reasons. You'll see that this probe has got a blunt tip. They do have probes that are diamond beveled so that they're trocars, but they're still much, much less sharp than these needles are. And this allows you to be able to do a very atraumatic introduction. And it also allows you to be able to add local anesthetic as you're advancing the needle through the tissue. And then it also, the third thing is, after you're done and you've taken the probe out, it allows you to put local anesthetic, a long-acting local anesthetic in the field to be able to do postoperative analgesia from it. So I think for all of those reasons, an introducer is important. So what we're going to do now is we're going to look at the first of these nerves that I ever started doing cryo on, which is the superior cluneal nerve. Okay. So the superior, and you'll need to come toward the feet. The superior cluneal nerve sits on top of the iliac crest. And it is a branch of T12L1, comes from the thoracolumbar junction, and will then travel through the quadratus lumborum muscle onto the top of the iliac crest. And there can be as many as 5 of these nerves. Most commonly, it's the medial branch of the superior cluneal nerve that gets entrapped because it's going through a canal. And so you'll get pain on the top of the iliac crest, but it is one of those pseudosciaticas. It'll go all the way down to the foot.
Do you find that they usually have pain at the thoracolumbar junction as well?
They often do, and I'll examine both places. And if it's more sore here, I'll treat the T12 first. And it may just be a facet that's referring to the iliac crest. But if they're primarily sore on the iliac crest, then I usually look at that distally first. And then I'll do always a diagnostic injection. I don't think it's appropriate to try and do a cryo when you haven't done the diagnostic injection, any more than I would think you would want to do an RF on a facet that you haven't identified as the pathology. So what I do is...
Your diagnostic blocks, are you doing them under fluoro?
I usually try and do the diagnostic block using the modality that I'm going to use for cryo. So if I'm going to do fluoro, then I do fluoro for the diagnostic injection. So I know exactly where I'm going back to. It's my landmark, my roadmap. If I'm planning to do ultrasound, then I'll do ultrasound for the diagnostic injection.
Okay.
So I'll examine the patient under x-ray. Ouch, that's right where they hurt. I put a marker on the skin where they're hurting. Now, one of the things that's interesting you'll see here is you'll sometimes see the transverse process of L5 hitting the iliac crest, and you've seen that before. You'll also see sometimes a traction spur along the medial aspect of the iliac crest.
Yeah.
That's actually an iliolumbar ligament pathology and not the cluneal. So those two get mixed up a bit. And in toward me. So usually you'll find the cluneal right on the top of the iliac crest, right about there. And so when
You do this in straight AP all the time?
I usually do this straight AP, yeah, unless there's a reason that there's a difficulty in visualizing, but it's, you know, I tend to be a very go right for where the problem is type of issue. I'll sometimes start a little bit lower, so if this is the iliac crest, I'm laying the probe this way, but most of the time I'm coming right to the iliac crest and sliding off just a little bit. Once I've found where I want to be, which would be right about there, then I'm going to do a local anesthetic, subcutaneous. And the problem is if you're using sensory stimulation, if you put local anesthetic on the nerve, now you can't find the nerve. And yet we'd like to have some extra fluid in those tissues to make sure that you can get a good ice ball. So I usually will inject saline. I also, though, want to try and decrease any bruising or bleeding, and I also want to decrease any of the size of the blood vessels in that area because they act as a heat sink. So I'd like to have some epinephrine in my solution. There's no commercial saline with epi, so and I can walk you through how you come up with it. But to get 1 to 200,000 of epinephrine in any solution, you add 5 mics of epi per cc. So the epinephrine is comes in a 1,000 microgram little vial. So that's 100 mics per hash mark. If I've got a 10 cc vial, I'm only putting in 50 mics, which would be 1/2 of those little hash marks. If I've got a 50 cc vial, then 50 times 5 is 250, and it would be 2.5 of those hash marks. You add it fresh, and you can do that to local, you can do that to any solution now. The problem with local anesthetics that have epi in them is, you remember that the epi is unstable in a basic solution. That's why you never put epinephrine and bicarb in the same IV during CPR, or ACLS, and so to keep the epinephrine stable and to have a nice shelf life, you have to drop the pH to 2. All right. Well, that A, hurts a lot, and B, we know because local anesthetics are weak bases that you've got much more of the drug in the ionized form, which can't get across the myelin sheath, which is why we add bicarb to our local anesthetics to decrease the pain on injection, but also to improve the shifting to the unionized form so it will go across the sheath. Your lidocaine with epi that's commercially made has got a pH of 2 compared to lidocaine, which is a pH of 6. So add the epi to the lidocaine. Now you've got a pH of 6 plus fresh epi. It won't last, it won't sit very long. You'd throw it away the end of the day, but it will get you that 5 mics per cc will get you the 1 to 200,000. So I'll then do an infiltration with local anesthetic, and I'm using usually a 27 gauge needle, and I'll go right on to periosteum. That gives me my depth. Now I know where my depth is. And then I'll use, just like we did when we were starting large IVs, I'll use the side of the needle to make a little break in the skin, because this catheter has got a shoulder on it, and it won't go through the tissues very well. I used to do a scalpel, but then that's an extra expense, and I've got something sharp right here. And I will also then, when I'm advancing this, I put the catheter right in my hand with the end in the palm of my hand and my finger at the edge here. So this gives me absolute control over this. And so I'm going to advance it very slowly, and it's very gentle. I can put a little bit of extra local anesthetic if something, but just a 1/10 of a cc, just the path of the probe, or the angiocath as it's going in. And so I've got complete control over that catheter. And I'm doing these under local with no sedation, so this is not an uncomfortable procedure. And then coming down onto the edge of the iliac crest. And so that's os here, and then I just slide right off.
Yep.
And so I can do it anywhere along here now, and I can move this in any direction. So once I'm where I want to be, I just take the stylet out, and now I'm going to be able to use my probe. I have to have a helper here to help me with the machine because this is all sterile here. And so I'll place the probe the way, where I want it to be. And then what we're going to do, and I'll let you do this for me, is you want to make sure you're set on stem, and we'll do times 10. There you go. And make sure it's set on sensory. And now you're going to turn this knob until the patient starts to feel it. So I take it up usually to 10. It's very sensitive. And if I'm not feeling it at 10, stop right there. Nope, keep it on, but just keep your hand on it. And then what I'll do is I'll move the probe until the patient says, ah, that's it, off immediately. As soon as they say, just turn it off, there we go. So as soon as they feel it, I turn it off. And that's important because you can overstimulate these nerves. Just like being in a room with a loud noise and you walk out and you still can't hear for a little bit. So you don't want to leave that stimulation on. And it can be uncomfortable as well. So you just want them to just begin to feel it, turn it off. Now I'll turn it back up, but I'll take it up to just 5. Nope, you're doing fine. Just take it up to 5. Now if they don't feel it, now again, I'm going to move the probe until they do feel it. Up, there it is, off. Okay? I'll take it down to 1. Now at that point, if they're feeling it, I may choose, because especially if I've got the big probe, 1 is probably close enough. If I've got one of the little probes, I may want to now switch to the 0 to 1, and now take it up to 5, which would be 0.5, and see if they feel it. And then as soon as I've gotten it now, I've gotten successive approximations, I'm right on the nerve, I then turn it off and switch to motor. There are not a lot of differences that I've been able to tell between M1 and M2. Okay. As it has to do with the frequency, but M2 is easier for me because it's right there. And then I take it all the way up to 20, back to times 10. That does 2 things. It reminds me to leave it back on times 10. But it also, I want as big a field in that motor stimulation to make sure I'm not anywhere near any of the motor nerves, and then turn it off. Now, at this point, I've found the nerve, and there's a little bit of a problem here because unlike RF, you can't now take the probe out and put the local anesthetic in. I've helped with EpiMed developing an introducer that has a side port so that you can inject local anesthetic in through that issue then. And so we're hoping to bring those online pretty quickly. But I take one final picture to make sure I'm exactly where I want to be, and then I'm going to start to freeze. Now, to do that, this is a positive system. There are some where you take your foot off the pedal to try and start to freeze. On this one, you put your foot on the pedal to start to freeze. I'll let you do it. You're going to switch to temperature there, and that just lets you monitor the temperature. The timer will start to go when it reaches -18. It'll start to activate. And what you're now going to do is step on the pedal. And for the first 30 seconds or so, the patients may feel pain because this is like touching dry ice. And I just walk them through it, 15 seconds, 25, you've got 5 more seconds, and almost invariably, as it beeps 30 seconds, pain's going away. And so it's very consistent. The one time there'll be a difference is sometimes if you're on primarily periosteum and not as much the nerve, the periosteum takes a little bit longer to freeze. If they're still hurting at 1 minute, I'll stop, let it defrost, give it a few seconds, and then start to freeze again, and that usually takes care of it. Okay. So go ahead, foot on the pedal, and it will start freezing. Now, the one thing I didn't talk to you about, and I think is an important one, and I'll let you keep on freezing for a minute. At 30 seconds, it'll beep again at 1 minute, at 1 minute 30, at 2 minutes. I usually do a 2-minute freeze, and then 30 to 60 seconds of a defrost. That defrost allows you to be able to get a bigger ice ball. because the ice after about 2 minutes no longer freezes any bigger. You can freeze for 15 minutes, it won't be, there's that beep. It won't be any bigger than that. I've done my 2-minute freezes, and now what I'm going to do, I'm letting it defrost. It's important to recognize that that ice ball takes a minute or so to defrost. And if you try and pull this out with the ice ball still in place, it will rip tissues, and that defeats the whole purpose. Now, I've actually had a friend who put the probe in a disc and pulled it out while it was freezing, deliberately, to try and do a discectomy with the disc material on the probe. But in general, that's probably not a good idea. So you let it defrost, and the way I know it's defrosted is I'm going to try and slide this angiocath off, and as it starts to defrost, you'll feel it suddenly give way. And now I know that that's fine. Before you actually go to put your catheter in, I think it's a wise thing to do to make sure that your probe is actually freezing. And so you can do that very simply, and I like to do that before the catheter is in place, because once you've done the catheter, you've sort of committed the patient, and you haven't checked to see that your equipment's actually working. These have got tiny, tiny tubings in here, and if somebody didn't do a good job in terms of trying to sterilize it, or if there's wet gas in the system, there'll be a problem. And so just before I go ahead and put my catheter in, I'll just go ahead and step on this briefly, and what you'll start to see very quickly is you'll see the frost occurring right on the edge of the probe. If there's a lot of moisture in the air, you'll actually see the condensation in the air. That's all I need to know is right there. Now, even though this was minus 70 degrees, the ice is an insulation, so I can touch this because though it's a little bit cold, and then as it defrosts, it just pulls right off. So then once I've gotten all of this in place, I'll now put a little bit of Marcaine or long-acting local anesthetic here, and then pull the catheter out, Band-Aid, and we're done. Excellent. I usually recommend them that they keep some ice on this for about 20 minutes on, 20 minutes off for the first 24 hours, and then either heat or ice, whichever feels better. And so the thing that is challenging is trying to get people to recognize that a 12-gauge catheter is tiny if you do it smoothly. Okay?
Sure.
Any questions?
No.
Okay.
Actually, one question.
Yes.
Yesterday evening you mentioned you freeze, you defrost, and then you
freeze again, refreeze, another
so
2 minutes.
And
defrost.
Basically defrost for
30 to 60 seconds,
so. Okay.
and then refreeze.
Another 2-minute freeze.
So a total of 5 minutes.
Okay.
So it's a 5-minute procedure plus however long it takes to.
And you're stabilizing the probe the
correct.
entire time, correct?
And that is also an issue. When you're looking at doing the fluoro on this, you want to keep your hand out of the field. That's the problem I've had with some of the handhelds, is that you can't take a fluoro image because you can't let go of this. But what I can do with this is I can hold it out of the field like this. But I'll tend to hold it with my hand on the patient this way.
Yep.
And it's for 5 minutes. It doesn't take very long. But it is important to stabilize it, especially when you're doing the defrosting. You went to all the trouble. Some people will move the probe at the defrost, and I said, well, wait a minute, I've gone to all the trouble to get right on the nerve. I'm just going to stay right where I am. But and so just keeping it stabilized.
Sure.
And actually, when it starts to freeze, it will stabilize itself usually. The bigger the probe, the more stable it is. You have to be a little careful with the smaller probes because they will bend, and that can kink the tubing that's inside of it. So you want to really do all your manipulations through the catheter. Okay. There are a couple of places where it is particularly unnerving to do cryo for a lot of people, and one is in the ribs. So let's move toward the head. The intercostal is probably the one that is unnerving the most to the patients. To the doctors, and it was to me too. The idea of putting a 12-gauge the way we usually do intercostals, which is perpendicular. You go perpendicular to the rib and then drop down. But if you notice, this has got a very long bevel, so you can be, this part can be underneath the rib, but this isn't. So one of the things that I looked at doing was to try and come parallel to the nerve. And I do this now for my rib blocks themselves as well. So for an intercostal, I'll tend to come fairly proximally. Depends on what you're really trying to treat. Sometimes you can do just the tip of T12, for instance, if you're looking at one of the anterior abdominal walls. But usually you're looking at rib fractures or thoracotomies, so you need to be fairly proximal. And so just coming up underneath the edge of the rib, and I come just over the rib, and just at the very edge of the rib, I come down and touch os on the inferior border. And the advantage of this system, this technique, is that you're parallel to the nerve, so you're going to have the greatest contact with the nerve.
Right.
And so you get a better freeze. So I come down onto periosteum, that's periosteum, and then just slide off, and then under. And so it'll actually put it up underneath the rib, but not in the pleura. Doing this left-handed, so it's and then up underneath the rib. I'm not paying. Go back to periosteum. We were having a discussion at dinner last night about at lunch yesterday about left-handed people. So they're at the edge, and then sliding off and underneath.
You can feel it.
You can feel it slide. So it'll look like it's on top of the rib, but it's actually coming underneath the rib. Yeah. So, and so then you do your stimulation, and you just have to be right at the very edge, because remember that the nerve is lying up underneath here. So when we do the perpendicular injection, we're trying to get into that potential space. With this technique, you're actually laying it on the nerve. And so in 20 years, knock on wood, no pneumothorax with this technique. So there are a few of these that you can do by fluoro: suprascapular nerve, the intercostals, the cluneals, the superior gluteal, the facets, but a lot of these are best done under ultrasound because they don't have the bony landmarks. So pudendal is one of those interesting ones where you can do it under fluoro or ultrasound, and there's some advantages and disadvantages of each of those. So if you're doing it under fluoro, you'd come right to the iliac spine. You can also do it under fluoro at the ischial tuberosity, and then you can do it under ultrasound looking at the pudendal artery at the ischial spine, or looking at Adcock's canal as you come up underneath in the lithotomy position. So, and then you've got nerves like the infrapatellar saphenous that are best probably done under ultrasound because you can actually see the nerve and they're really not much in the way of bony landmarks. Okay.